Today, I'm going to start talking a little bit about some different pathologies. And since it's one of the most common, actually, I will start talking a little bit about coronary artery disease and its influence on cardiac mechanics. Although today we can only start with this, it's a relatively large topic, but at least it's nice to get it as an introduction. Okay, coronary artery disease. So this is actually the bulk of adult cardiology. And all of it is related to the perfusion of the heart muscle itself. So what you see here is, so in this case, this is an example. These are a couple of examples of synchrotron images. In this case, from animal hearts. This is actually a rabbit heart. These are red hearts, but it's just to show you the complexity of the coronary circulation in some ways. So what you see is here you have the aorta, the aortic root. And so what you have is that from two of the three cusps of the aortic valve, you will see just on top of the valve, there's coronary arteries coming out. So there is a right coronary artery, there's a left coronary artery. In humans, the left coronary artery almost immediately splits in two, what they call the LAD, the left anterior descendant, and the circumflex coronary artery. So that clinically, we're mostly talking about patients having three coronary arteries. So one right and two left coronary arteries. What you also see is, so when you integrate it with the tissue, and that's what I told you before also, so the coronary arteries, they are the main coronary arteries, they are actually on top of the epicardium. And so they are actually in grooves. So what you see is when you look at the heart itself, so there's what we call the coronary grooves. And so that, as I said before, the outside of the heart remains relatively smooth and more or less spherical or circular, right? So these coronary arteries, so they are epicardially, and then they start to get into the myocardium. And here you see the complexity of this. So you see actually there is quite a lot of vessels. And in this, so this is actually a maximum intensity projection from a very small slab of tissue. Here you see the coronary arteries, how they go throughout the whole heart in this movie. But what you can nicely see from here, so here you have a large epicardial vessel that immediately starts to branch out. And then what you see is it immediately branches into a very, very dense network of very small vessels. And as you see, this is actually, in a way, independent, at least in parts of the heart, independent of the fiber structure in some ways. It also, of course, has to be integrated in the fiber structure. So in this case, it goes from epi to endo. And what you see is actually, it's also very, very dense. So what you can say is that roughly 10% of the volume at end diastole, so when it's relaxed, of the muscle is being taken by vessels. And I think they are actually, this volume is actually quite important for the deformation. I think this is some recent results that we're getting, but at this moment, that's not the most relevant. So what is important is that we have this dense network that is coming from epicardially. That means that the smallest vessels and the most distal vessels, so the vessels the furthest away from these coronary arteries, are in the endocardium. And we will see later on, or I already mentioned it, because of this, we will see that the endocardium is actually much more prone to problems when it comes to perfusion problems than the epicardium. Okay, so when we look at clinical imaging and how this is being described, and this is actually also very important, especially when we go to quantification later on of deformation and perfusion territories, is what we do in clinical practice is we try to get a standardized segmentation of the myocardium, of left and right ventricle, and then assign specific coronary arteries to this. So this is being used for diagnostic use, but also then later on to do quantifications. So what you can see is like we have the different views from echocardiography. So we have short axis views, we have long axis views, and the apical views. And what you see is that most of the echocardiographic views are actually segmented into 6 standardized segments. And what we can do is we can also make a bullseye out of this. So a bullseye plot, which is that you take the left ventricle, and what you do is you actually open it up and you map it to a circle in such a way that the central segment is the apex. The more you go towards the outer radius, this is the base. And then what you have is that mostly the right ventricle is located, in this case at the left side, because we use the anatomical radiologic way of looking at it, which means that it's looking from the feet towards the head. So, and then each of these segments are numbered, and there's a standard kind of nomenclature and standard amount of these segments. Now, these segments roughly correspond to coronary artery territories. So what you see is that the left ventricle, a large part of the left ventricle is actually perfused by the LAD. So here you see this is like a scheme of a human heart. So two coronary arteries coming from just above the aortic valve, a right coronary artery, which is perfusing the whole of the free wall of the right ventricle and part of the base of the left ventricle. And depending on dominance, so depending on the individual, you might have a bigger or a smaller right coronary artery. And so if you have a very big coronary artery, then actually a large part of the left ventricle is actually also perfused by this right coronary artery. And then, as I said before, the apex predominantly by the LAD, the anterior wall also, and then the other parts are by the circumflex. But again, depending on the individual anatomy, where the sizes of the three vessels with regard to each other can vary, what we will have is we will have these territories. Now, this is already important. The fact that the territories are not uniquely assigned to a certain standard segment in individuals means that if we use these standard segments for quantification later on or to do statistics, we almost for sure are making errors. And the reason for that is that sometimes territories are from one artery to the other. So when we split patients into coronary artery disease of the different vessels separately, we will make an error when we average. And obviously also it's like, because this is individually variable, that means that also these very strict segments, these rigid segments that we would have when we would divide it in 6, is of course also in a way very artificial, because every person, this territory will become bigger or smaller. That's already what I mentioned at some point when we look at kind of strain and we would measure strain and we would average it in these segments. What we might do is we might average different coronary territories. And then of course, is one artery would have a problem and the other one not. What we do is we are mixing actually substrates in some ways. So what is also relevant is that what scientists and engineers have been trying to do, and now especially in the era of machine learning and automated analysis, is what you try to do is you try to recreate diagnostically these segments. So what you do is you say, okay, we measure a certain parameter in the different places in the heart, and then we average it out in this segment, and this is what we report. When you do that by computer, when you do that automated, you have always these very rigid segments. But when a cardiologist would do an echocardiography and they would look at these segments, what they actually do is, if they are interpreting and then writing a number in for example, a plot, what they actually do is they might extend or shrink or move a little bit this territory, knowing that, okay, this will correspond to that, this will correspond to that. So there is an intrinsic fuzziness on this citation, which in clinical practice, when it's being done, is very often being compensated by the way that the echocardiographer or the cardiologist is doing the reporting. While if you do everything automated, you cannot do that. So this is a big discrepancy. And this is something that when you're a researcher in this field, you actually have to take into account. We've been discussing that before also. This is like, in a way, the uncertainty, which might be related to an uncertainty in measurement, which is not ideal, but which is also, of course, related to the physiological variation or the anatomical variation, which is intrinsic. So that's important to keep in mind. So when we're talking about coronary artery disease, so we're talking about atherosclerosis in some ways. So what's happening is that you actually get a problem of mainly like lipid accumulation in the different layers of an artery. In another class, we will talk a little bit more about the structure and the abnormalities in larger arteries. But what you will see is that you see it already in the scheme. So an artery roughly has a one cell layer endothelium. So that's the layer which is in contact with the blood actually, and that's extremely thin, but it's very, very important because it's biochemically very, very active. And what you then have, because as we said before, arteries have to be able to adapt to a certain flow condition. Right? So the flow through the artery will be determined by what is needed by the organ which is connected to it. For example, when you do exercise, you need to have more flow going to your muscles, for example, or to other organs. What happens, or what needs to happen, is that this artery needs to dilate, needs to become bigger in order to increase the flow. And this becoming bigger and shrinking and so on, this is done by smooth muscle cells, which form like a large layer within these arteries. And then you have an outer layer, which is more rigid and gives also some support. Well, it's a bit more complex than this, but this is roughly the case. And so what you will have is that in some people, and it's also partially genetically modulated, but also related to smoking and diet and things like that, what you will have is you have an accumulation of lipids, cholesterol, for example, in between these layers. And so what happens because of this is that, of course, the wall becomes thicker and lumen becomes so the lumen, the inside of the vessel, becomes narrower and narrower. And at some point, and that is the biggest problem with this, is that these plaques, as they say, that they actually can rupture. So what happens is if you get that this cap, so the endothelial part, if that is rupturing, what happens is that you actually bring the blood in contact with the lipids or in contact with the inner part of the vessel. And what you then get is immediate clot formation. So what happens is that you get a clot, and this clot can actually totally obstruct this coronary artery. Now, there is a lot to do with composition of these plaques, and whether this is a stable plaque or an unstable plaque, because these plaques can be calcified. Calcified plaques are relatively easy to detect, for example, with CT imaging, but calcified plaques are probably more unlikely to rupture than like a pure lipid plaque, for example. But again, that's a discussion for some other time. Now, one of the things which is also still important is that the place where you get these plaques coming is actually partially related to the local flow conditions. And things like the amount of flow and wall shear stresses, for example, will determine how this happens. And what you see is that the chance of getting these abnormalities is actually higher, for example, in bifurcations, or where you have more complex anatomy of the different vessels. And the coronary arteries, since they are very complex and since they have rapid branching, then what you see is that they are prone to this coronary artery disease. Now, another thing which is also important to know when we talk about coronary artery disease, for example, as compared to strokes or kind of vessel disease within the brain, is that actually when we look at the coronary circulation, is that each vessel is almost uniquely perfusing a certain territory. And so here you see, for example, a mapping of part of the coronary arteries. And you see here, for example, when you look at the LAD, say that here at this bifurcation, you would start to have a problem and you get an obstruction. What you will see is that there will be no flow, or at least less flow, going to this area at risk. And that can become an infarction. I'll show you later on what an infarction is. But what is important in the heart, that in normal people, and actually in most patients also, this piece of tissue is uniquely perfused by this coronary artery. And this demarcation is actually very, very sharp. So you can have here a piece of tissue, and a millimeter further, a piece of tissue is actually being perfused by another artery. And that makes, of course, that the heart is quite prone to problems if there's a problem in one of the vessels. If you compare that, for example, with the brain, because of course a patient that has coronary artery disease very, very likely also has problems, as you can see here in the scheme, with the carotids, for example. And so when you have carotid artery disease, you have a chance, of course, that you get a blockage of a carotid artery, which would perfuse the brain. But the brain, by default or anatomically has much more redundancy, or has redundancy, let's say it that way, because what you have in the brain is that you have two carotid arteries abroad, you have your vertebralis artery in the back, and actually in the middle of the brain, you have what's called a circle of Willis, and these are small vessels that normally don't have a lot of flow, but these vessels connect all the different large vessels. So that means that, for example, if one of your carotid arteries would block, then actually the perfusion of the piece of brain that normally get blood from this carotid artery can be taken over actually by the other arteries through this communication through the circle of Willis. So this is what we call kind of collateral flow. Now, most patients do not have collateral arteries in the heart. There's very, very small ones when you go in anatomically, but mostly it's not enough. Patients that are lucky enough to have or develop, if you have long-standing coronary artery disease, it might be that you develop actually collateral circulations. So when you have that, then of course you're much more lucky, and that actually prevents you from having a real myocardial infarction. But in general, and that's important to know, as I said before, the perfusion territories are very sharply demarcated in the coronary arteries. Now, I'm not going to go in detail, but as you know, the standard procedure in order to kind of relieve a blockage of the coronary arteries, and whether that is a severe obstruction or already a full obstruction. So if it's chronic coronary artery disease, what you see is that you get slowly narrowing of the coronary arteries. And at some point, mostly if your narrowing is over 75% or something like that, what you start to get is you start to feel symptoms, especially when you do some exercise. Yeah? Because also what is important is to know that, as I told you before, arteries, and so coronary arteries, they have this adaptive mechanism to change their diameter depending on the flow that is needed. And so, of course, what is happening is if a patient is developing a narrowing in the coronary artery, and so the lumen becomes smaller and smaller, what you get is that you get actually a reaction of this coronary artery that it dilates in order to keep the diameter more or less normal. And so this you can do for quite a long time, but of course that means that you don't have any reserve anymore. And so the reserve that you need is, as I said, when you do exercise, your coronaries have to dilate in order to bring more blood to your heart muscle. And in a normal person, this is about up to a factor of 5, for example. So by coronary dilatation, you can increase the flow by a factor of 5 when this is needed in order to do exercise, for example. But if you have coronary artery disease, then this dilatation is happening in order to compensate for the narrowing. And of course, once you're fully dilated, and when you then would do exercise, of course, you really have no reserve anymore, and you're immediately kind of out of breath or start to even feel chest pain when you do exercise because there's absolutely no reserve. And so that makes also that, as I said before, exercise testing is something which is really important, because it might be that at rest, everything looks normal, but your artery is already in a so dilated state that you have no reserve anymore. And so the standard treatment is to go in there with a very small balloon through a catheter and then blow up a stent. And so it's mostly like a metal stent, and this way you open the territory. Now, there's a couple of things also which are important. It's like, for example, if you have a total occlusion of a coronary artery, you have to, as quickly as possible, reopen this. And the question is, what happens if a patient is for a long time with a full occlusion? Will you still open it, yes or no? So these are questions that we will also later on cover. These are things which are actually important. So to decide who needs a stent and when it's too late in order to put a stent, these are questions that are clinically relevant and where we should provide answers by trying to study the kind of cardiac mechanics, cardiac deformation, the overall structure and remodeling of the heart, and then what's happening during exercise. But we'll come back to that later in a minute. Now, what is also important is looking at the dynamics of a myocardial infarction. So what I told you before is the coronary arteries are epicardially and then go into the myocardium. So the most distal part is the endocardium. So that means that if you have a total occlusion of a coronary artery, what you start to see is that the endocardial wall is starting to become necrotic. So the first cell death, so irreversible damage, will happen at the endocardial side. And the longer this occlusion is taking, the more you see that the extension, so that what we call the transmural extension of an infarct is growing. So this is what we call like the wavefront phenomenon. So coronary artery disease always starts in the endocardium, and then when you have like a really long time of no perfusion, then you see that you get a transmural infarction. And also, of course, you will see that the extent of within the kind of area at risk also increases. So the area at risk is the perfusion territory. So you have a certain coronary artery. If you would occlude that coronary artery, there's a certain amount of tissue which doesn't receive blood anymore. That's what we call the area at risk. And then depending on the time, what we see is that more and more, starting from the endocardium and then towards the full perfusion territory, we start to get irreversible damage. Yes?
Well, wasn't there oxygenation coming from the endocardium? Probably.
Pardon? Yes, we come back to that later on. Yes, so there is an extremely thin layer. I'll show that later on. So this is the simplification that in clinical practice is being used. And so that means that also when you're looking at problems, if you see a patient that has, for example, mid-myocardial cell death or problems or epicardial cell death or problems, then it's highly unlikely that this is related to coronary artery disease. So because we know that it has to start endocardially. And also what we said before is what is important is like when you start endocardially, we know also that these are more or less longitudinally oriented myocytes that are there. So it's again longitudinal function, which would change the earliest. Now, when you have a patient coming in with chest pain and a potential myocardial infarction, so what they call an acute coronary syndrome. So an acute coronary syndrome means that suddenly you have an occlusion of a coronary artery. That's related to chronic coronary disease, where very slowly over a long period of time, the coronary arteries are starting to become smaller and the patient becomes more and more symptomatic. So in acute disease, the clinical way people mostly work is do quickly an ECG. And here you see a typical ECG with these very large changes, what they call kind of ST elevation. This means that it's a very large infarct. Now, when you have a smaller infarct, you don't see this necessarily, these ECG changes. So these are sensitive in order to detect large infarcts, but not at all for smaller infarcts. The other thing is that they look at blood markers, and especially troponins is something that is being used now a lot in clinical practice, and that is sensitive in order to start to detect cell death. Myocardial cell death is related to the release of these biomarkers. And obviously, when you have suspicion of this, what you do is you do a coronary angiogram. So where you inject contrast in the onset, so in this case, the left coronary artery. So this is the catheter here. This is the start of the artery. You inject contrast and you see here a big blockage of one of the arteries. So this means that you have like a full obstruction of a coronary artery. And then in the same session, what you mostly do is you insert a stent in there in order to relieve it. So this is what they call like primary PCI. So PCI is percutaneous coronary interventions. And primary means that as soon as there's an onset of symptoms, you rush to the hospital and day and night, there's a team ready to put a catheter in you and a stent if needed immediately. And that has saved a lot of lives and has also reduced the infarct size a lot, so that you see that now most patients that get a cardiac infarct, they end up with relatively small tissue damage if they're fast enough. But if you're not immediately reacting and calling the ambulance, then of course you start to get this kind of full transmural myocardial infarction. Okay, so what happens when you have a full transmural myocardial infarction? So when it becomes chronic, so after a while, what you see is that the wall becomes very, very thin. and it becomes scar tissue. So it becomes predominantly collagen. So it's like necrotic tissue. And what you see, it's like it's very thin and it's quite bright, so it's whiter on the images. And a very typical image, so in this case, magnetic resonance imaging here of a large apical infarct. So you see this patient has very, very thin wall here in this part. So almost half of the ventricle almost is gone. And you see this is not contracting. So you see it stays the same. And what you see is it's the base which is contracting. And actually what you now see is that this apex is actually a little bit kind of wiggling within the pericardium. So you see the outside of the heart is still not changing, as I said before. And within that, you have this typical motion pattern. And so here you see short axis views where you nicely see in the base part, you still see that there's quite some thickening and that the circumference is changing. So this is like more or less normal. It's probably even hypercontraction. Here in this apical part, you see that there's no change whatsoever. The circumference is not changing. There is no thickening. The wall is thin and it's only like wiggling within the heart. So this is like a kind of full infarct. Now, what are things that we can look at also with imaging? So as I said before, a coronary angiogram gives you the anatomy of the coronary arteries, can say where it's occluded. What also is being used quite a lot besides echocardiography, of course, which is one of the things, is looking at magnetic resonance imaging. Magnetic resonance imaging is not so much used in the acute situation. And even echocardiography is rarely used in the acute situation, because acutely we mostly go with ECG changes and of course symptoms, then biomarker changes, and then we very quickly go to a coronary angiogram, because then we can in the same session, of course, do the intervention and put a stent. While if you need to have day and night echocardiographic examination at your disposal in order to do that, that is logistically very difficult, and sometimes also it's like, okay, in clear cases, it would be a waste of time. You really need to be as fast as possible. So there, people are still struggling how to put imaging, for example, in kind of a pipeline of acute things. But when you do imaging, so with, for example, magnetic resonance imaging, what you can do is this is like delayed gadolinium enhancement, as they say. So you inject gadolinium contrast, then you wait 10, 15 minutes. And what you then see is that the contrast will accumulate in infarct tissue, in scar tissue. And what you see here actually is, this is really a severe transmural infarction. And what you see here is that the endocardial wall has contrast, the epicardial part also has contrast, but the mid-myocardial does not capture contrast. And this is actually not because this is not infarct, this is actually because the tissue is so much damaged that the contrast can't even reach there anymore. So this is like the core of the infarct, but you clearly see that this is transmural infarct by the fact that you have this clear endocardial layer of enhancement. So you have endo and epicardial, so this is a full transmural infarction. Here is another example where you look at perfusion. So if instead of just waiting for a certain time until the contrast is kind of redistributed, what you do is you look acutely at how the contrast moves through the tissue. Then you can see that contrast is going in normal tissue. And here you see a rim of subendocardial tissue where you see there's no enhancement. So this is like a subendocardial perfusion defect. If you do not kind of revascularize this quickly, this will become a subendocardial infarction, for example. What you also see, and that's another thing which is important, and we come back to that next time, what the influence is on deformation, is that if you have an occlusion of a coronary artery for a certain amount of time, and then you reopen it, what you often get is you get kind of tissue edema. Edema means an accumulation of an increase in the water content locally. And that is, of course, what you do is when you kind of occlude the coronary vessel, what happens is that locally within the cell, all types of proteins and so on are being generated, and you get a change in the local molecular concentrations. And if you then reopen it and you get normal blood there, what you immediately get is you get osmosis, and you get water accumulation around the cells and also within cells. And for example, with T2 imaging and MRI, you can actually visualize this. As I said, we come later back to that, what the influence would be on the cardiac mechanics. And so this way, with this type of imaging, and so with late enhancement, what you can do is you can look at the transmurality of an infarct, for example. But as I said, this is mostly done for chronic infarctions, and it helps a lot to see whether there is scar tissue, yes or no. Now, to come back to a little bit more the detailed structure, and that's also Gabrielle talking about your question. So here's an example of what we did with synchrotron imaging, and this is kind of an example of a rat model, so a rat heart where there was a ligation of the LAD, and here you see it there. So here you see a normal coronary artery or coronary system in the rats. Here you see one where there was a ligation, so there was like a string being tied around the LAD. So you see there's no coronary arteries anymore, but what you see is that after several weeks, what you see, and this is also something that has not been described a lot, but apparently you get a kind of hypervascularization from venous flow. And that's what you nicely see here. But what you clearly see is that you get a very thinning of the wall. So this is what I showed you before. So this is a really transmural established infarction. And if we look at the fiber orientation, what is actually very interesting is that when you look in this infarct, what you see is that actually the fiber structures is actually maintained. You still see these different layers. What we said is this change of the fiber orientation from longitudinal at the epi towards circumferential in the endo, towards longitudinal and circumferential in the mid, towards longitudinal again in the endo. That is actually retained. So it looks like this is really collapsed in some ways. And when you look in more detail here, so here are examples. So this is the synchrotron image. This is actually corresponding histology image. And what you now also nicely see is that there is a layer in the subendocardium and a layer in the subepicardium of a millimeter or something like that, which is actually totally preserved. And this is related to perfusion by diffusion. So as I said before, normally your perfusion is through coronary arteries, but of course, oxygen can diffuse through tissue also. But the diffusion distance is very small. So what you see is that there's an endocardial layer where there's diffusion of oxygen from the cavity, from the blood in the cavity. And so that's why there's a preserved layer in the endocardium. And similarly, the epicardium is, of course, what we said before. There's a small layer of fluid around the epicardium, or kind of between the epicardium and the pericardium. And it seems like that is also protective in order to keep part of the tissue. And it's in between. What you get is, it seems like that what's happening is that you get cell death. So you get myocardial cell death because of this. And because of the cells kind of getting out there, what you get is you get a collapse of the matrix. And it seems to be that this matrix is the thing that determines, in some ways, this fiber orientation, which is in a way logical, because of course the cardiomyocytes are embedded in the matrix, and this matrix supports the myocytes, so they have similar directions. And the other thing that, of course, also happens is that because of this, what you get compensation. So in this case, you get hypertrophy compensation in the peri-infarct region, so around the infarct, but where there's still normal perfusion, you actually get an increase in the size of the cells, and you might also have it at the contralateral wall. But we'll talk about that later. So about a hypertrophy response through either pressure overload or a change in contractility. Okay, I think this is enough for today. So this was more or less the introduction of coronary artery disease. And so next time we can go over and look at images like these, where we see kind of visually even abnormal deformation, and what type of deformation that we can actually see when there's coronary artery disease, different types of coronary artery disease, either acute occlusions of a coronary artery or more chronic changes, chronic kind of decrease in perfusion, and also what happens when you reopen the vessels.